Welcome back to movementprofessional.com. So this video is a personal case study of how I look at treating my own injuries. So today I just had a little bit of a pop in the back of my knee towards the head of the fibula. So when I felt that, it's a little alarming, not necessarily painful, but I was doing jiu-jitsu, finished my bout of rolling, and then as I expected later on, you started getting a little soreness in that area. So first thing I think about is not necessarily what's damaged, but maybe what area of the body might be involved. And then, so when I'm thinking the head of the fibula, that's a common muscle attachment for the short head of the biceps femoris, which is one of your hamstring tendons. It's also an attachment to the lateral collateral ligament, or LCL. So I want to go through a process of differential diagnosis, see which one is more likely to be involved, if not a little bit of both. And I'm expecting this is a brand new injury, a couple hours old, that there's going to be inflammation that's starting to build up, so everything's going to be a little bit sensitive. What's important to know, and what I've learned about myself, but also just working with clients over the years, is that early pain is going to be expected, and it's really not diagnostic of much. It's not diagnostic of how severe the injury is, because you're supposed to get inflammation early on as part of any healing process, and that inflammation creates sensitivity to the tissues and it creates pain. So if it's the most severe pain you've ever had in your life, it doesn't tell you how bad any structure is damaged. It just tells you that it's probably a new injury, and it might be something that's new to your body and to your nervous system. So you do have to kind of appreciate that. You listen to the pain, and your body's telling you to avoid the things that hurt in that moment, but it doesn't tell you how bad the damage is. All right, so you don't necessarily need to know that. What you do want to find out, and what I think is important, is to be curious about what hurts and what doesn't hurt. And I think too often you just assume that there's pain in the area, so you're just going to avoid anything that would be anywhere near that extremity. And to me, that's problematic. Even early on, even a couple hours into a new injury, you really want to be exploring what hurts and what doesn't. And I like to think of this as developing a pain profile. I want to know what provokes my symptoms, I want to be as specific as possible, what angle, what intensity, and then I get more information about where I am in the process, and then I also have baselines to see how I'm progressing going forward. And I think that's really important. And the way I like to think about this, and one of the reasons I'm doing a video like this, is I often think to myself, what do I want to get out of a physical therapist or a medical professional? I don't want somebody to tell me what to avoid. I want somebody to show me how to be curious, show me how to explore. So I'm showing you how I explore my own injuries, and then I'll maybe do a couple videos to see how I'm progressing forward with it. So as I'm looking at the differential diagnosis, is this some type of LCL thing? Is it a short head of the biceps thing? I'm gonna first put myself into just a cross-legged sitting position here, because if I cross my leg here, I'm able to feel the LCL pretty good on the outside here. And I can feel that, it's a pretty thick ligament. I can feel it's intact. It's actually not even painful to touch. So my assessment is it's intact. It's certainly the pop I heard was not necessarily from that being ruptured. So that makes me a little bit relieved. Where I do feel the tenderness, though, is right on the back end or posterior end of this head of the fibula being the long bone of the lower leg, or the skinnier bone of the lower leg that's more on the lateral side. Again, a common attachment, but it's a very common area to get a pop or cavitation, because it's such a mobile bone, because it's a smaller bone. So it can just move in a way that creates a little bit of a pressure release, and that's any type of pop that you get where you're cracking your knuckles or you're getting adjusted by a chiropractor. It is some type of release of pressure from the body. So that pressure, if it's a great pressure, and oftentimes if it's a pressure that's new to the body, it can be alarming. It comes with some inflammation and some injury afterwards, but it doesn't necessarily tell you that something is ruptured. On the other end of it, if something does rupture, you tend to get a pop. So it can be indicative of a rupture, but a lot of times you'll get some type of popping or cavitation without there being any serious problem whatsoever. So that's what I'm trying to discern. I'm hoping that nothing serious. So because I have the tenderness behind the head of the fibula, I'm thinking more along the lines of the short head of the biceps. So what does the short head of the biceps do? It's a hamstring tendon. So the hamstring flexes the knee and it also extends the hip. But down here by the distal attachment at the head of the fibula, it's going to have way more to do with bending the knee. So one of the things I can feel pretty easily is even just a little bit of knee bend without load will bring a little bit of the symptoms on, but not too great. So I want to assess that. So one of the ways I'm going to do that is put myself on my back with my heels, and actually I'm going to start with the calf muscles on the bench here. All right, so first thing I want to assess is I'm going to think about where the hamstring attaches at the hips, and I'm just going to create this little bit of a pelvic tilt first, and that gets the hamstrings on both my right and left side engaged, but more at the hip where it attaches at the sit bone. All right, so that feels already a little bit sensitive, but not too bad, something I can certainly tolerate. All right, from that point on, then I want to create a little bit more pressure down with the left versus the right, and that I feel right away is starting to provoke the symptom. So now I'm getting a sense of, even with the leverage being closer, more proximal to the knee, as opposed to if I go by the heel, I'm imagining that's going to be a worse, and it is, then that's where my onset of pain is with these hamstring isometrics now. So one thing I can start with right away, though, is trying to gauge how much intensity I put into this isometric. So the more proximal I keep it, the more I think of what's going on at the hip, and the less I think about pressure down in the calf, the more I'm going to take the stress out of the knee and bring it up into the hip, and it'll be less likely to be provocative. So I'm going to work just on that motion here, where I'm thinking more pelvic tilt, thinking about my back pockets moving to the back of the knees with minimal amount of pressure down into the bench. I can even bias my right a little bit more than my left right now. The other thing I want to think of is my inner thighs engaging, so I may bring my knees a little bit closer together, so I feel like I'm getting a little bit more assistance from my inner thighs, hamstrings, and then even my abs. So I'm able to use my hamstrings, but I'm getting a lot of support from the rest of my body. All right, I'm going to do that 5 seconds, 5 times, and I want to see what my tolerance is before I feel the onset of pain. So again, I'm looking for this onset of pain, and that's going to give me a lot of information about what I can do currently today. And what I often find with this is the more reps I do, the more I'm engaging muscles proximally around the core and the hips, the less I start to feel the knee. All right, so as opposed to trying to avoid or immobilize the area, what I want to do is I want to use my body better. In this moment, I want to use more of my body so that this area doesn't take as much stress. All right, and that's what I'm trying to assess early on. Okay, so the other thing that I could play with in this position is, what does it feel like to have my feet out a little bit more? So my hips are starting in a little bit more internal rotation. And if I start there, I can actually put a lot more pressure down into the bench with less pain in the knee, versus if I go external rotation, that actually even feels better than being straight on. So these positions now I can use more of my hamstring, but I'm just at a different angle, and they feel better. So again, I'm trying to be as specific as possible with what promotes it, but also at the same time know what promotes it. So another thing that I'll look at is the gait cycle, because I'm noticing that, especially after sitting for a little while, the initial step, I'm limping a little bit. And I want to understand why and where in the gait cycle the problem is. So I'm going to slow gait down into 3 positions. Stance phase, where I'm just on one leg. Heel strike, where this heel comes down and my weight's still on the back leg. And then rollover, where I put my weight forward onto the front leg. So I roll over onto the back toe. So I'm going to go real slow through this. Feels fine here. Heel comes down. Roll over. Still feels fine. So as I'm moving slowly with gait, there doesn't seem to be any pain. So there's something about me getting up and just transitioning positions where my body is making me walk a little bit differently. That's actually what's more painful. And I see this a lot, that a gait dysfunction or some type of limp is actually unnecessary. It's moving you farther away from optimal gait mechanics but it's just our body's way of overprotecting. So as we just start to slow the gait cycle down, and the more we understand about the gait cycle, we can either find exactly where it starts to hurt or see that it actually doesn't hurt that much once we start to clean up gait mechanics. All right. The other thing that I'll tend to bias is if I'm feeling this outer side of the knee, I may want to hit my outer heel a little bit more. It creates a little bit more stability on the outside of my body. It turns me to the left a little bit more, and I can bias that with some slow walking and then try to increase the pace with similar mechanics and just make sure that I'm not getting any of the symptom that I might have felt periodically with just getting up from a chair or starting to initiate gait. All right, so that's going to be something I think is important. I'll tend to do gait with almost any individual that has any pain with walking, whether it's from the ankle, the foot, knee, hip, is that you want to really understand the gait cycle, be able to slow it down and then speed it back up, and make sure you can do that without symptoms, so you can really understand where within the gait cycle, which can be pretty complex, the symptoms are coming from. So hopefully that makes sense. I'll try to do videos to keep you posted on my progress, but I just wanted to do this to kind of get inside my head as a physical therapist for 15 years. What do I think about when I get injured? All right, because you want to practice what you preach, as far as like, I want to be someone who's active, but I think when you're a therapist and you work with people who have orthopedic injuries, you want to put yourself in situations where you actually may get injured too, and how do you deal with that injury? So I feel like it's useful to be putting my case studies out there as much as possible, and I'll certainly be putting myself in positions to get injured from time to time. So I look at it as an opportunity as a therapist to educate. Hopefully that makes sense. If you have any questions, you can go to movementprofessional.com. I'll see you next time.